This module is on clinical correlations of the brainstem auditory evoked potential. There are several indications for ordering a brainstem auditory evoked potential. These include assessing brainstem abnormalities and dysfunction, including identifying structural lesions of the brainstem, especially within the posterior fossa, as well as identifying possible demyelinating conditions. Please note that with the improvement and advancements in neuroimaging, especially MRI, these techniques are used less often now. Another indication for the BAEP is to assess hearing, especially in patients who cannot cooperate for a traditional hearing test. At Sick Kids, we do not do this very frequently, as most children with questions of hearing difficulty are sent to audiology where they will receive a more thorough assessment. The other population where we would be interested in hearing dysfunction is in newborns in the NICU. Currently, as a standard of care, Toronto Public Health and the NICU test every newborn using an AABR, an automated auditory brainstem response. The AABR is similar to what we do in neurology, except that it is tested at 35 dB, which is a lower decibel level than the 70 or 90 dB that we typically use, and therefore the AABR is more able to detect mild hearing losses. Another indication for the ABR is within the operating room. The BAEP is used intraoperatively to monitor the integrity of the auditory pathway, especially as it passes through the brainstem and posterior fossa. There are some caveats to consider when interpreting the brainstem auditory evoked potential. First, peripheral abnormalities, including hearing loss or any occlusion of the outer or inner ear, will affect the BAEP and preclude interpretation. The BAEP, if used for assessing hearing, is only a hearing screen or rudimentary hearing test, as the BAEP protocol that we use in neurology only tests at limited decibel levels and only with a broadband click. We do not do the full hearing test, which is done at different decibel levels and different frequencies that would be done by audiology. And please note that the wave 1 may be seen in brain death, or it can be seen in brain death. The wave 1 is generated by the 8th nerve and is therefore a nerve response, which can be activated even when the patient is brain dead. The later waveforms, from wave 3 onwards, will not be seen in brain death as they are measures of brainstem function. The brainstem auditory evoked potential is very technically challenging to record in neonates, as it is a very small amplitude response and is therefore easily obscured by muscle or movement artifact. As well, in the baby, there might be blockages in the ear that degrade the quality of the stimulus that they are hearing. So it's absolutely important to see a wave 1 on the tracing before interpreting an abnormal or absent brainstem response. Another caveat is the brainstem auditory evoked potential is a brainstem measure only. The normal latency of a wave 5 is under 10 milliseconds, and therefore only measures activation of generators in the brainstem. The BAEP cannot be used to comment on cortical functions or cortical deafness. Another recording protocol optimized for cortical responses must be used if there's a question of cortical function. There are some diseases that affect the wave 1, and if it is known that a patient has one of these conditions, then the wave 1 cannot be interpreted. However, if a wave 1 is still observable, even if it's poor, then the interpeak latency can be used to assess brainstem function. So even if a patient has one of these conditions, the BAEP can be useful as long as a wave 1 is identifiable. Here are some conditions that affect the wave 1. Anything that causes a hearing loss will affect the wave 1. This includes deafness, any blockage to the external ear or ear canal, including by fluids or by objects, an inflammation of the ear canal or inner ear, and any damage to the eardrum. Also, some inner ear diseases include labyrinthitis and Meniere's disease. Finally, any demyelination that affects eighth nerve function, including multiple sclerosis or Guillain-Barré syndrome, may affect the wave 1. There are several diseases known to affect the brainstem auditory evoked response. Tumors of the brainstem, including acoustic neuromas and cerebral pontine angle tumors, or CPA tumors, affect the conduction of the signal through the brainstem and will increase the interpeak latency between the waves 1 and 3. Any degenerative or demyelinating condition that affects the brainstem will also affect the BAEP. For example, Friedreich's ataxia, leukodystrophies, and multiple sclerosis all affect the integrity of the signal passing through the brainstem. If the signals are still conducted through the brainstem, but the conduction is less intact, for example, early in the disease process, then this will be observed as an increase in the interpeak latency between waves 1 and 3, or 3 and 5, or throughout the brainstem between waves 1 to 5. However, if signals are not able to be conducted through the brainstem, then this will be observed as absent waveforms in the BAEP. There are several criteria for abnormality of the BAEP. Abnormalities related to the wave 1, either latency or amplitude, indicate a hearing difficulty. If using amplitude for the interpretation, typically the peaks within the BAEP are similar in size, and so if the wave 1 is more than half the size of the wave 5, it is considered abnormal. Another criterion for abnormality is interpeak latency. This is the time between peaks of different waveforms and reflect the time it takes for the response to be conducted between the generators of the respective waveforms. For example, an increase in the interpeak latency between wave 1 and 3 indicates increased time required for the response to travel between the generators of the wave 1 and wave 3, which are located in the lower brainstem. Any interpeak latency increase above the limits of normal between waves 1 and 3 and 5, or 1 and 5, suggests dysfunction within the brainstem. As well, amplitude can be considered. As just mentioned, the amplitudes of all the waveforms should be approximately similar, so a low amplitude wave 5, where it is 50% smaller than the wave 1, would also suggest a brainstem dysfunction. If all the waveforms are absent, the test cannot be interpreted, as we do not know if the patient has a hearing problem. The wave 1 must be intact for us to interpret later waves. This is a chart showing the various possible BAEP abnormalities and their clinical interpretation. If the BAEPs are absent bilaterally, then one needs to rule out a technical problem, or it may indicate bilateral eighth nerve lesions. If the BAEP is of low amplitude, or if all of the waveforms within the BAEP have increased latency, and this includes waveform 1, then that would suggest some sort of peripheral hearing loss or an eighth nerve lesion. It's very important to ensure that the stimuli are loud enough for the patient, as the BAEP would be of lower amplitude if the stimuli are too quiet. If the peaks after a normal wave 1 are absent, this would suggest a dysfunction of the eighth nerve or a pontomedullary lesion, or a lesion in the lower brainstem. If there is increased latency of the wave 1 with normal interpeak latency of waves 3 to 5, this also would suggest a peripheral hearing loss or an eighth nerve lesion. If waves 1 and 3 are normal and wave 5 is absent, or if the ratio between wave 5 to 1 is atypically low, meaning the wave 5 is 50% smaller than the wave 1, this would suggest a brainstem lesion. If there is an increased interpeak latency between waves 1 and 3, or between waves 3 and 5, this would suggest a lower or upper brainstem lesion, respectively. If the patient is cooperative enough for testing at different decibel levels, then a latency intensity curve could be plotted. If this curve is shifted upwards, but the entire curve remains parallel to a normal curve, this would suggest a conductive hearing loss. If the latency intensity curve is shifted upwards predominantly at the lower intensities, but remains normal for the higher intensities, then this would suggest a sensory neuro hearing loss.